Good evening, all. Welcome to this Health and Wellness series of June 2021. I am Abba Sahib Kale, Maharashtra chapter leader for Global Association for Corporate Services and Joint Secretary for Business Resilience Committee. I have with me two well-known doctors today, Dr. Sanjeev Mehta and Dr. Arun Mihira. I personally thank Mr. Mukesh Ajmera, my dear friend and guru from Fire and Security Association of India, for making this session live today. He introduced us to this both of doctors. In fact, I heard both of them a couple of weeks back, and I think we at GSS should invite them to talk about this very important topic of pre and post-COVID aspects. I personally have come out of COVID 10 days back and then understood the importance of this subject. I think we get lots of knowledge from different universities. One of them is WhatsApp, and make our own opinions. I really appreciated one comment from Dr. Mehta last time, that even we try to teach doctors nowadays, that sort of humongous knowledge is available in public domain. So it's better. In Marathi we have a kahavat, ardhavat dhyan ghatki, adha dhyan bahut dangerous rehta hai. So let's not follow that half knowledge path, but make ourselves well aware of what to do and what to not. So before we start, I request my the colleague from FSCI, Mr. Mukesh Ajmera, to say a couple of words here about the doctors. And sir, thank you very much indeed for helping us to connect to Dr. Sanjeev and Dr. Arun. Over to you, Mukesh.
Thank you very much, Avasab. Good evening, gentlemen, everyone. My name is Mukesh Ajmera, and I'm a small businessman doing business of fire protection, business, building automation, safety, security, and few of the life-saving equipments. Today, I'm pleased to introduce two very learned and very well experienced, very well-known doctors. Dr. Arun Mihira, who is a known cardiothoracic surgeon attached to various hospitals in Mumbai. He has his own two hospitals in Surat, TriStar 1 and 2. And the learned Dr. Sanjeev Mehta. Dr. Sanjeev Mehta is one of the very famous chest specialists and pulmonary specialists. And I have been knowing them for a long time. Dr. Sanjeev Mehta is recipient of many accolades, and Dr. Arun Mihira as well. That Abasab will take in detail. But it is extremely nice of them to have agreed to come and educate us on different aspects of COVID. And they will take the session further forward after Abasab's introduction. And I sincerely and genuinely thank both the learned doctors for considering my request and agreeing to come forward to address all of us. Thank you very much. Good evening, all of you, and let us hear the interesting presentation, see and hear the interesting presentation and talk by both the learned doctors. Thank you very much once again.
Thank you, Mukesh ji. It is indeed always pleasure to be associated with you. And with this, I welcome both the doctors, Dr. Arun and Dr. Sanjeev. The program is scheduled like this. We'll have presentations from both these individuals, and question answer session will be at last. Attendees can ask their questions through chat box or Q&A section there. And I think we will have more than 10-15 minutes for specific questions. Meantime, I will request all the attendees to wait for the details, because I think both the doctors will cover in-depth subject. So you'll have most of the answers till end, but still if you remain with any questions, please feel free to post them. So first, I will introduce Dr. Arun Mihira. He's consultant cardiothoracic surgeon in Bridge Candy Hospital, Lilavati Hospital, and Nanavati Hospital. He has founded 2 super specialty hospitals in Surat with state-of-the-art total bed strength of 230. He's a gold medalist, MBBS surgery, MS surgery, best outgoing student, and university gold medal for surgery from, I think, Mumbai University. He has awarded with Motibai Patel gold medal. Then Dr. M.D. Desai, best outgoing student gold medal, awarded by Srimati NHL Municipal Medical College, Ahmedabad in 1977. Mrs. Saraswati Jagmohan Parikh Gold Medal Award by Gujarat University in 1982. Dr. Mehra has received special award to eminent medical men for distinguished achievement of higher order awarded by the Indian Medical Association in December 2005. He has performed more than 5,000 coronary artery bypass operations, and he's a specialist in total arterial grafting. Dr. Mehta returned from London and joined Jaslok Hospital, Bombay in 1995. He's a specialist in radio surgery, artificial grafting, and total arterial grafting using Lima-Rima Y graft. Dr. Mehra has several research papers to his credit, over 30 of which have been published in required international journals. Dr. Mehra performed the first successful ECMO bridge to recovery procedure at Jaslok Hospital in a code blue survivor. The patient had an uneventful recovery. I think I can read on his entire biography, and it is full of achievements and lots of credentials. We welcome Dr. Mehra. Over to you, sir, for your presentation. As suggested by both of you, we have around 35 minutes for both of you, and then remaining time we will utilize for question and answers. Over to you, sir.
Thank you, Mr. Abasaheb Kale, and thank you, Mukesh Ajmera. Thank you for all the nice words. And I hope in this I'm able to justify all that you have said. So this talk is quite timely. I hope you can see my presentation. Hello.
Sir, you're not yet shared. Can you just share the screen? Yes, sir. Now it started. Yeah. If you can put it in presentation mode.
Yeah. Right. So this talk is quite timely. We are now in a position where we are preparing for the 3rd wave, and may the 3rd wave never happen. So I have 2 roles to play in this talk. One is my role as a cardiac surgeon. I am attached to Jaslok, Bridge Candy, and Lilavati hospitals, but the other cap that I am wearing is that I have 2 hospitals in Surat, and right from the beginning of the first wave, we converted one of the hospitals into a COVID hospital. So we have an experience of having treated more than 3,000 cases of COVID in our hospitals. We also treated a large number of cases as OPD patients. We then gave vaccination to, first we gave the vaccination to all the healthcare workers. Then we vaccinated almost the entire police force of Surat. And then we vaccinated the senior citizens. And now we are in the process of vaccinating the general population. So we have given more than 4,000 vaccinations, and we hope that this vaccination drive continues. So why is COVID spreading like wildfire? So here I will take the help of an Urdu poet. गिरते हैं शाह सवार मैदाने जंग में, which means that those who are standing erect and those who are riding a horse, are the ones who fall in a battle. वो तिफल क्या गिरे जो घुटनों के बल चले. So the small elements that crawl on the field are very difficult to get rid of. So this is exactly something that we are seeing with COVID. On the one hand, we have mankind, who is the epitome of development, and we are losing mankind in this war against COVID. And what is COVID-19? What is the virus? The virus is not even a living being. So the virus is a smallest element. It isn't even a living being. It is just a protein. If I go to the next slide, what is the coronavirus? It is not even a living being. It is just a protein with a covering. It enters the body, comes out of the envelope, enters the cell, and uses the cell materials to replicate itself and multiply. It then infects more cells and it causes disease. As opposed to that, the other infectious elements, the pathogens we call them, like the bacteria, the fungus, the protozoal parasite, or the multicellular parasite, the multicellular parasite is at least visible. So it is not as if it is an invisible enemy. The bacterium has got a cell, the bacterium has got a nucleus. So we can at least kill the bacterium. The fungus again is a large structure. Although the fungus is also difficult to tackle, but the virus, because it is just a protein, it is extremely difficult to tackle, and therefore we do not have almost any medicine that works directly against the coronavirus. All the medicines that we have are indirect. They work on the effects of the virus, but the virus itself does not get destroyed, and therefore the virus continues to travel from one person to another, and it keeps on spreading. So in tackling this virus, are we sleeping with the enemy? The viruses are like sleeper cells. They lie undetected within asymptomatic hosts. Whenever this asymptomatic host, whom we call the carrier, he meets someone else, the virus is transmitted to the new person. The new person may remain asymptomatic, the new person may get infected, or the new person may spread it further without himself or herself getting any symptoms. This chain we have to break somehow if we want to succeed against this virus. So these are the ways of contagion known very well to everybody. It spreads by coughing, it spreads by droplets which are spread from the nose or mouth when the person coughs or exhales. And therefore there is only one thing that one has to understand, that if one has a strong arm in one's armamentarium, that strong weapon is a face mask and social distancing. So face mask, social distancing, and hand washing, however unexciting they may appear, however primitive they may appear, these are the only weapons that are going to help us to stop this pandemic. And one cannot overemphasize this. So this is another short summary on the origin of the virus. This has been in the media a lot these days, whether it is laboratory grown or whether it came from bats. We leave that for the media and the University of WhatsApp to decide and the politicians to decide. So let's get on with the job of how to identify the virus and what are the characteristics of this disease. So as we said, that from the time of infection, there is an incubation period of 4 to 5 days, but maximum within 14 days of the exposure. Now, as a large number of patients continue to remain asymptomatic, this prodromal phase is difficult to estimate. Therefore, it is difficult to identify the person who is yet in the incubation period and yet may be a spreader, which is why the precaution of mask, the precaution of hand washing, the precaution of social distancing has to be universal. It is not proven that once you have taken vaccination, you are not to wear masks. I know that there are experiments going on in France, there are experiments going on in England, where people who have been vaccinated are being permitted to go without masks, but those experiments are still experiments and they have yielded limited results. So at the moment, as the knowledge available today, mask is our strongest defense to date. Now, why does this occur in waves? The technical term for this is the R factor. Now, R factor is the average number of successful transmissions per case. So if we have one infected person, if he infects more than one person, the disease will spread. If he infects no other person, then the numbers are stable, and in 14 days, this will slowly disappear. But that is not going to happen. He is going to infect less than one case at least, and as long as RO is less than 0.1, the numbers will decrease. So we saw at the peak in India, at the rising trend, the RO was as high as 4, and therefore we had a strong wave. We reached a figure where we were infecting 3.5 to 4 lakh persons every day. Then our R factor came to 0.9, and now the cases, and now the pandemic is on the recession, and this wave on its recession, now we are seeing 1 to 1.5 lakhs. We hope that the RO continues to become 0 and we get rid of this second wave. I introduced this slide because of the element of fungal infections that we are seeing in the media today. So we have got a lot of fungal infections, and one of the theories of why fungal infections are occurring is that we were giving zinc to everybody. What we had observed at the time of the first wave was that when a person develops COVID infection, his zinc levels drop. So we started giving the persons zinc. However, it is now theorized that zinc is an important nutrient for the growth of fungus. So this lowering of zinc levels in the body was part of the body's own response to increase its defense against fungal infections. So we are now not supplementing zinc to either patients or for prophylactic reasons, and we are permitting zinc levels to go down in the hope that they will continue to defend the patient against fungal infections. So what are the prognosis or clinical outcomes for infectious diseases? So a person becomes infected, he may either remain asymptomatic or he may become symptomatic. If the patient is asymptomatic, he may go for full recovery, or he may continue to harbor the infection and have chronic infection. The symptomatic patients also may have full recovery, fortunately something that happens in 98% of cases. Few patients may have sequelae or disability, and unfortunately we may lose about 2% of the total cases. So this is again the pyramid of disease, where a large portion of patients get infected, a smaller portion of patients get symptomatic, a much smaller number of patients, say around 20%, will require hospitalization due to hypoxia, due to fever, or due to the other complications, the development of pneumonia. Of these hospitalized patients, we may have three components. One is the group that completely recover. The other are the long haulers, the one who recover, but they have some disease or other left, and 2% of patients whom we might lose. So what are the clinical presentations? These are now well known to everybody: fever, fatigue, dry cough. The important ones were, important and new ones were loss of taste and loss of appetite, diarrhea in a fair amount of people, and the loss of smell. So these were typical symptoms which are seen in COVID disease. These symptoms were more seen in the first phase. They are less seen in the second phase. Now, when you compare the various coronaviruses, for MERS, the mortality was 33%. For SARS, the mortality was 10%. But for COVID-19, the mortality, fortunately, is only 2%. So this is a disease which has got a lower mortality, but it has got a much faster and much wider spread. So what happens to the virus once it enters the respiratory tract? It goes into the lungs, it attaches itself to the epithelium. On the epithelium, there are some receptors. It attaches themselves to those receptors with the form of spikes, and then it continues to cause inflammation. It may cause blockage of the bronchioles or the alveoli, and then it may cause pneumonitis. Once there is inflammation in the lungs, hypoxia occurs, and then there is a requirement of oxygen, the requirement of advanced drugs, which we shall come to. Now, how is the virus isolated? Here we are seeing showing the virus being isolated from the nasopharynx of an animal, but this is how the virus is isolated. Once collected, it is kept in a viral medium, and then it is taken to the laboratory where the polymerized chain reaction, RT-PCR means real-time polymerization chain reaction. So the virus is multiplied and then it becomes identifiable. Now, if somebody has noticed in the RT-PCR test, there is a CT value. So how many times does the virus have to multiply in order for it to become detectable? So if this CT value is less, it means that the virus is more virulent. If the CT value is more, it means the virus is less virulent. So what does this virus do once it enters the cell? So this viruses are of two types. There may be a DNA virus or an RNA virus. The coronavirus is an RNA virus, therefore it's named corona. Now, what an RNA virus does is it acts as a template. It uses the DNA as a template. It goes into the cell, it forms a template, and it goes for protein formation. This is what happens in a normal cell. Now, in the coronavirus, it does not require a DNA in order to multiply. The RNA transcripts itself, it multiplies itself, which is why its growth is rapid and difficult to control. So we have two methods of detecting the infection. One is the gene detection, which is the direct virus detection. This can happen from day 0 and maybe up to 15 to 20 days till the infection is there. So this is the RT-PCR test. The other is the serological detection, which does not detect the virus itself, but it detects the after effects of the virus, the production of antibodies. So when the virus enters the body, it produces antibodies. These antibodies are of two types, IgM and IgG. IgM is the antibody that forms early. It is the antibody of active disease. IgG takes about 2 weeks to form, maybe 10 days to 2 weeks, and this is the protective antibody. Now, there is a third type of antibody called the spike protein antibody, which forms after vaccination. So we can detect either the effectivity of the vaccination or the past history of disease by the production of IgG antibody. This is once again detection of details of the polymerized chain reaction. This is the other method of detecting it called the GNAT, which is a little faster. So as we said earlier, what are antibodies? So antibodies are a trace of previous infection. So whenever a virus comes into the body, antibodies are formed. These antibodies, as I said earlier, are of two types, IgM or IgG. And we can detect these antibodies, and these antibodies tell us that in the past there was an infection. How do you clinically manage a patient who has been detected to have COVID infection? So there are two distinct situations. One is the non-serious presentation, which happens in the outpatient setting. So these patients just require isolation. These patients can get isolation at home. The vast majority of these patients can get treatment at home. They have to monitor their saturation. They have to do simple exercises, steam inhalation, and they may be prescribed some medicines. Maybe some doctors prescribe Fabiflu at home. So that is the non-serious presentation. Patients who are unwell, who keep on getting fever, whose fever does not go away in 1 or 2 days, whose oxygen requirement increases, whose saturation drops, who develop respiratory failure, are the ones who require hospitalization. So how long is isolation required? This is a difficult question to answer. In the initial phases, people used to say that isolation should be for at least 7 days since the first symptoms appeared. Then for healthcare workers, because healthcare workers were in short supply, they started to say at least 72 hours since recovery of symptoms. 3 or 4 days after the symptoms have recovered, the healthcare workers were permitted to come back to work and look after other patients. Now, I would personally feel that up to 14 days after infection, one is actually an active carrier, one is spreading the virus. Up to 15 to 20 days, there is risk of shedding of virus, which is live, and therefore this virus can be spread. So the answer to this question is, how long should be the isolation? The answer is between 15 to 20 days. The next question, is a negative RT-PCR mandatory before coming back to society? The answer to that is no. So 20 days after the first appearance of symptom or cure of symptom is how long we need to isolate. Obviously, this is not the complete answer because a large number of people will not have any symptoms. So no answer in corona is actually complete, but these are the guidelines. So what about the unwell patients who require hospitalization, who develop pneumonia? So the cornerstones of management are infection control. That means controlling the spread of infection, controlling the spread of infection to the rest of the lung, controlling the spread of infection and secondary infection like bacterial infection and fungal infections, and supportive care. So supportive care in terms of treatment of the fever, treatment of the symptoms, treatment of cough, and giving oxygen in the form of a mask, or some patients may require to be ventilated. So these are the methods we use for infection control. We need to use the PPE kits. You've all seen photographs of PPE kits. So these are the supportive measures, basically giving oxygen to the lungs and ability of and supporting the circulation so that this oxygen which reaches the blood then circulates to the rest of the tissues. So this is how the disease affects the lungs. The corona infection comes into the lungs. there is leakage of water into the alveoli, and because there is water into the alveoli, oxygen does not cross this barrier, and therefore hypoxia sets in. Later on, pneumonia develops, and then the patient may require ventilation. So these are the signs and symptoms of respiratory compromise: shortness of breath, coughing, using accessory muscles to breathe, not being able to talk in full sentences, and a bluish tinge or cyanosis to the extremities. What is mucormycosis? We looked at this earlier. Any patient who is in the ICU for a long time, who is on antibiotics, who is on steroids, or who has low immunity, develops secondary fungal infection. There are two types of fungus. One is the white fungus, which is probably aspergillosis, or the black fungus, which is mucormycosis. See, normally fungus lives in the soil. It also lives in the body, in skin creases, in nails. So whenever the immunity goes down, these fungal infections, who are opportunistic, they seize this opportunity and they spread within the body. We've been through this. I'll briefly go through the various drugs which are available for the COVID-19. One of the most famous drugs is remdesivir. However, the current status of remdesivir is that it has failed all the clinical trials. In the initial phases, it was thought that remdesivir along with Tosalyzumab would reduce the hospital stay, and it would also reduce the incidence of the patients within the hospital going on the ventilator, and probably reduce the mortality. But none of the trials were able to prove reduction in mortality. So the current role of remdesivir is borderline. We do use it in the initial phases when the patient fever does not break in easily along by paracetamol, but there are no clinical trials which have proven that remdesivir will reduce the mortality in case of COVID-19. The second drug is favipiravir, commonly known as Fabiflu. This drug was first commonly used in Japan. Once again, this drug, although it has got the benefit that it is available orally, that means it can be taken by the oral route in the form of a tablet. Whether it actually helps, we do not know. The third drug is Tosalyzumab, an expensive drug. Tosalyzumab, in the earlier trials, we had thought that Tosalyzumab would help prevent a patient with disease going on ventilator. However, currently, we do not think that Tosalyzumab is of much help. Unfortunately, Tosalyzumab does reduce the immunity greatly, and we have seen a lot of patients who initially seem to have benefited from Tosalyzumab, later on after 20 or 30 days developed severe infections and succumbed. So at the moment, I personally am not using Tosalyzumab. Tosalyzumab is not available either, but that is the role of the Tosalyzumab. Another similar drug, Itolizumab, it was once again thought that it was going to help in patients in whom there was a sudden severe occurrence of disease. It would help the patient and reduce the incidence of ventilation, however, and reduce the mortality. However, that is not proven either. Another drug, Ivermectin. Ivermectin is a drug that has been around for a long time. Ivermectin is an anthelmintic, means it is a drug that is used for other pathogens like worms in the body. In the test tube, or in vitro or in the chemical laboratory, ivermectin does have an action against the coronavirus. However, the dose required for such an action is huge, and such a dose cannot be given to the human being. Therefore, ivermectin's role is also borderline. Similarly, chloroquine was initially thought to have a preventive role. We call it prophylactic role. We all did give chloroquine to all healthcare workers when vaccination was not available. We did think that it provided some protection, but we are not sure. Zinc, I have already discussed. Vitamin C is supportive. Steroid. Although steroids have been used rampantly, the role of steroid is limited, and I think we will wait for Dr. Sanjeev Mehta to tell us which are the patients in whom steroids should be used. Anticoagulant. Now, anticoagulant, COVID-19 does cause a lot of thrombotic activity in patients. So the role of anticoagulants is to prevent this thrombosis, and anticoagulants have been very useful. Both steroids and anticoagulants in selected patients have been shown to reduce the mortality in COVID-19 cases. 2-deoxyglucose is a recently introduced, reinvented magical drug. However, the way it is supposed to work is that it is theorized that the virus requires a lot of glucose to multiply. If we replace this glucose by a glucose analog, which does not actually provide energy, we will reduce the multiplication of the virus. This theory, however, is yet to be proven, but this has been launched with much fanfare. We do hope that it works. That's all that I can say. Monoclonal antibodies also have got a limited role. Convalescent plasma also has got a limited role. It is theorized that this role is only there during the first 6 or 7 days of infection. And at that stage, to give monoclonal antibodies or convalescent plasma is probably overkill. Since this is a talk on corporate involvement and how corporates can act, I would like to bring in a little bit of the problems that we in the healthcare sector are facing in tackling corona disease. We all know that the government spends not more than 1% of its GDP on healthcare. The central government, which controls the budget, only takes limited responsibility for healthcare because healthcare is a state subject. Whenever there is a different government in the center and a different government in the states, we see the state government trying to render futile all attempts by the central government to take any effective action. The answer to this is probably insurance companies. Now, in India, insurance companies collect premium in cash and expect the hospitals to provide cashless facility. In India,
Go ahead, sir. We can see the slide.
In India, the insurance companies collect the premium in cash and expect the hospitals to provide cashless treatment. In the USA, big companies like Kaiser, and in the UK, big companies like Bupa and Nuffield, they actually invest in hospitals. They either open their own hospitals or they invest in existing hospitals. They give huge research grants. They have special rooms. They support the hospitals because in the end, it is the patients that they have to be looked after. One day's ICU treatment can cost 30,000 to 70,000 rupees easily. However, whenever you see a big bill of the hospital, media come and start attacking the hospital as if the hospital has committed a crime. I just want to give you an example that in one day, a patient can use 21,600 liters of oxygen.
Dr. Saab, sorry to disturb. Can you put it on presentation mode? Very important slide. So people want to see it clearly.
Is that better? Yeah.
Yes. Thank you, sir.
Yeah. So one day's ICU treatment can cost 30,000 to 70,000 rupees easily. Now, if you give only 10,000 rupees, see, I don't mean to say anything against any of the high courts. I don't want to be in contempt of any of the high courts. But if you make a limit of 10,000 rupees for per ICU bed per day, the hospital has no option but to cut corners. How will the hospital work? So I think it is corporate responsibility to understand that the same medicine that cost, I'll give you the example of a car. A C segment Honda car that costs $4,000 to $5,000 in the US, which is the equivalent of about 3 to 4 lakhs, costs 15 to 20 lakhs in India. The same medicine that is produced, the same ventilator that is produced in the USA. Actually, we import most ventilators from Netherlands. We add import duty, we add GST. The ventilator costs twice as much in India. Yet hospital bills are 10% of the hospital bills in the USA and UK. All of you who travel abroad, all of you who have children abroad, you know how much they pay for health insurance and what hospital bills are like. So our hospitals are taking a lot of the brunt of the healthcare. During the first corona wave, there was a hospital bill of 15 lakhs, which was widely advertised in the Delhi press. Do we know that this bill of 15 lakhs contains government taxes of 4.5 lakhs? Hospitals pay 18% GST and there is no input tax credit. There is also an 18% GST on oxygen and on oxygen plants. All doctors pay 43% income tax. All this is added on to the hospital bill. In the USA, the universities pay the doctors a large percentage of their salary and a small percentage comes from the patient. In the UK, the NHS pays the entire salary of the doctors and that salary is about 8 to 10 times higher than the salary in India. In India, the doctor's salary is paid by the patient, and in India, the government takes this salary from the doctor, which ultimately comes from the patient. So these are the problems of healthcare, which, see, I am a warrior, I am a soldier, I should not complain. A soldier should not complain about the food he gets, a soldier should not complain about the ammunition he gets. He has to go there, stand against the enemy and fight the enemy. I am not at all trying to say that the responsibility of a doctor is less, the responsibility of a healthcare worker is less, or the responsibility of a hospital owner is less. But there is a limit to the responsibility, and the corporate sector at least should be aware that the rupee that they are spending on insurance is going in to buy shares in other companies. Why should a insurance company like the life insurance company invest in Reliance? Why should life insurance company invest in housing? Why should life insurance company invest in Tata Steel? Life insurance company should invest in hospitals because it is its prime responsibility to protect its patients and its clients. Thank you so much.
Very insightful session, Dr. Arun. I think indeed a great pleasure to hear from you the basics, and most important, the questions you posed.
I do apologize for my last slide, but
In fact,
doctors always stay quiet, and doctors do not bring out their problems to the fore, and therefore it is assumed that everything is hunky-dory.
Actually, I appreciate for that last slide.
Dr. Sanjeev Mehta is actually sitting in his OPD with patients, but he is wearing a brave face and he has got California or some such holiday destination in the background. We can ask his wife when he last took her on holiday.
Yeah. So thank you. I think the last slide is one thing which is our responsibility, and rightly pointed by you. We all Indians are respecting you as soldiers. So I take it from my heart. I just came out of ICU 10 days back, and I was just thinking on the same line. I think these young health workers as well as you doctors are rescuing us from this very deadly disease. So hats off to all of you. Entire corporate services fraternity represented by GSS. I think we are really thankful to you. With this, we come to the second round of our discussion. We have another great doctor with us, Dr. Sanjeev Mehta, who is MD, FCCP, FAP, SR, chest physician, and he's working at Lilavati and Arogya Nidhi hospital. He is founder and chairman of Maharashtra chapter of Indian Chest Society. He is founder of a group called LIFE, which is Lung India Foundation. He is founder of Mumbai Chest Group, known as MCG. He is recipient of presidential citation in the year 2018 from Chest ACCP, which is American College of Chest Physicians. He is recipient of Dr. C.V. Ramakrishnan Oration from Indian Chest Society, and his past chair, Council of Global Governance, Chest ACCP. I invite Dr. Sanjeev Mehta to please share the dais and help us with further details on this COVID series. Over to you, Dr. Sanjeev Mehta.
Thank you very much. Thank you for inviting me. I'd like to thank this wonderful organization. But above all, I'd like to thank my dear friend Mukesh Ajmera, who has been a dear friend for so long and who invited me here to be alone, not only with you, but with my other very dear friend, Dr. Arun Mihira. So I'm going to, most of what I have to say has already been very well covered by Dr. Mehra. I'll just go over a few things very quickly. And so let me see if we can. I think some overlap is good, but let me just get you on to a few things. What I am going to cover a few things which I feel are helpful and important from the patient's perspective. So let's look at this. So we've had a pandemic for now over a year. You're all familiar with this graph that I've shown you. We started in early of March of last year. We had a huge, that time was a huge peak in, say, July, August, and then we got hit by this second peak. Luckily, across India, wherever you see, the numbers are coming down, and that is fantastic news. So I think I begin this talk with very good news. Delhi is, you can see, Mumbai today's numbers are only 650. So that's again, or 800, that's great news. And across the country, that's great news. The other good news is that Netherlands lifted the travel ban from India today, so which also reflects our less numbers. A question that's asked, and I think Dr. Mehra talked about it, is whether we are going to see a third wave. There's no question there will be a third wave. To me, the question is how big is the wave going to be? As you can see here, whether it's going to be a very sharp peak like this, it'll be a broad peak like this, a very slow onset, we don't know. But the reality is we are going to get a peak at another wave, and we'll see how it happens. Now, to me, looking at Mumbai data, and I cannot talk about all the other data, our first peak that we saw in Mumbai were all the slums. In the second peak, we did not see we are not seeing any slum people. We are seeing all housing society members who got the peak. What it tells me, and this I think is something that you want to hear, to me, this means that there is immunity that develops after an infection. This group of people who got the virus last time are not getting it this time. If I look at the first epidemic that happened outside China was Italy. And Italy, North Italy, is not peaking now. I say this because many people are very scared of the third wave. I think it will not be so intense. I do not think it will be so severe. But though Times of India today says it will be very severe, I don't think so. Also because there is a lot of vaccination going in. So with herd immunity developing, I think it's going to be okay. A lot of people are talking about whether children will be affected in the third wave. And my feeling is that they've also been infected already. In fact, it's usually assumed that if the mother is infected, the children are already infected. So I am very hopeful as I see this wave coming down that probably the worst is behind us. On that positive note, let me go further. This is a coronavirus. You already have had some inputs from Dr. Mehra. This is a photomicrograph of the coronavirus. And the reason why it's called corona is if you look at this, this looks like a crown, isn't it? What you see here, few fuzzy things here, you can see them better here, again very fuzzy here, are the spike proteins. And you see one coronavirus that is dividing into two. This is a schematic of the same thing. And we can make out that this is the corona, this is the RNA, this is the core of the virus. It forms an outer shell, and these on the outside, you see these spikes, they are called the spike protein. I know that today, thanks to the University of WhatsApp, everybody is a corona specialist, and everybody's talking about spike protein, and I get asked which antibodies to check. The reason why the spike protein antibodies are important, that's what develops after the vaccine, is because the spike protein binds to angiotensin converting enzyme receptors, and then that acts like a key to the lock that allows the virus to enter the human cell. In fact, it is said that the new mutation makes this key even more efficient, and that is why this new variant is more infectious. So the whole purpose, the whole rigmarole, this entire gamut of immunity is meant only to create antibodies that prevent the binding of the spike protein to the natural receptor. They're not, our immunity doesn't that much kill the virus as much as it blocks the binding of the virus to the natural protein, and that is how you get protected. So if you're getting general antibodies, they're antibodies to these parts. If you're getting spike protein antibodies, they are the protective antibodies that bind to the spike protein, preventing it from getting into the cell. So that I hope clarifies in your mind this question about spike protein. Once the virus enters a human being, unfortunately, it circulates in the entire body. And unlike the flu virus, which stays only in the airway passage, Unlike the hepatitis virus, which stays only in the liver, unlike the AIDS virus, which stays only in the blood cells, this horrific virus circulates in the entire body and causes damage from head to bottom, top to bottom. Now it affects the brain, and very sad. We have seen a lot of patients with headache, but what worries us is we see patients with encephalitis. Unfortunately, that's a really bad outcome marker. People who get encephalitis don't do very well. A lot of patients I see have got conjunctivitis. Red eyes can be symbol of. In fact, people ask me, what is a symptom of COVID? Well, every one of these can be a symptom of COVID. So conjunctivitis, we all know about the loss of taste, loss of smell, loss of taste, cough. At least 80% of the patients are going to get lung involvement. That's the number one organ that is damaged. The other serious organ that is damaged is the heart and the cardiovascular system, where there is a complete inflammation. You can see heart and cardiovascular system. There's an inflammation of the airways. So it's a vasculitis kind of a thing. It's an arteritis, it is a venulitis, it's a capillaritis. The entire vascular system gets affected, and we get patients who come to us with complete heart blocks. We get patients who come to us with heart attacks. The first presentation of a patient is a heart attack, and that's because there's inflammation of the blood supply system. So I think the two major organs that are seriously affected are the lungs and the heart and the blood vessels. And that's the one which most of our long-term treatments are targeted. If you saw Times of India app today, it says even the intestines are affected, but that's really not true. The blood supply system to the intestine is affected. So it's part of the vascular system. I've seen patients getting pancreatitis and none of them have survived. So really a very bad virus. It can affect multiple organs in the body and cause a lot of damage. So please be aware and please be protected. Don't mess around with it. I see people not wearing masks, not taking protection. This is a virus that you cannot play with. This is a virus that you have to treat with the highest level of respect and caution. So these are the lungs. The virus enters through the airways, nose and lungs. And once it enters the lungs, it causes a lot of damage. The lungs are soft, smooth, supple, very thin-lined substances, tissues from where gas can exchange. The moment the virus comes in, it causes thickening and destruction of the lung tissue. And the moment the lung tissue is destroyed, lung cannot do what it is supposed to do, and that is it cannot change oxygen from carbon dioxide. So the oxygen falls as first step, and then the carbon dioxide rises, and that patient goes from type 1 to type 2 respiratory failure. The reason I mention this is, if the patient gets type 1 respiratory failure, that is low oxygen, you as a family member can give oxygen support. If it gets worse, then this patient needs to have non-invasive ventilation or mask ventilation, where you have to push air under force, and that is called non-invasive ventilation. And of course, if everything fails, then invasive ventilation. I'd like you to bear in mind, and I tell this to my patients, that if a patient has reached a stage where the patient is on a ventilator, survival is very less likely. Even anywhere in the world, it's about 20%. Not because there's anything wrong with the ventilator. The reason is the lungs are already so damaged that they are at a point of no return, as is the rest of the body. So I think this is a bit about the lungs. A lot of people come to me with this thing called CT score. Oh, for God's sake, please don't get into CT score. The Radiology Association tells us that that has really no value, and absolutely true. You can see that even though, if I was to say, the CT score remains the same in day 2 and day 5, but the disease has progressed so much that this lung on on my right, I think on your right of the screen, is severely damaged. What you're seeing here now is extensive involvement of the lung. You can see a lot of damage in the lung. Obviously, if it is so damaged, you cannot get oxygen, and that's going to be affected. And these are what CT scans of pneumonias, CT scan of COVID pneumonia looks like. Very, very damaged lungs, and we get extremely worried because this patient is not going to do well, at least in the short term. This is a very nice picture some time ago, which I saw, that ultimately every lung is going to get, or at least the severely affected lungs are going to get hit. And you can see here, this is the normal healthy lung. This is looking at the metabolism, how much of it is functional, working, oxygen uptake. And you can see here, the metabolism shows good lung functioning, whereas in these pictures, the lung is burnt out. This is the long-term damage. And I'm afraid with the way COVID has hit India, there is going to be an epidemic of respiratory failure patients happening in the next 5 to 20 years. COVID will go out of your memory. Damaged COVID lungs are going to be here for the next 15 to 20 years. So please take your lungs very seriously. The heart will be temporary, but the lung damage is going to be long-term. In fact, I'm giving medicines to prevent that. I was the first one to start. I hope that we're able to take care of this. Otherwise, it's going to be a huge problem. So this is the information. I have been telling people now, and we didn't know this earlier. We thought that, COVID is like any flu virus. You take medicines, it gets well in a week. You don't take medicines, it gets well in 7 days. It's not a 7-day virus. It is not a 2-week virus. It is, at the moment, we see 6 months virus. Many patients who have had COVID in the past will come back to us and tell us that, doc, I'm yet not well, as late as, say, about 2 to 3 months later. So people who've been in hospital, anywhere between 60 to 80% of them will have long-term complications. Remember, the long-term complications are weakness, breathlessness, lot of anxiety, lot of distress, especially people who've been seriously ill, depression, concentration problems. People say, I have brain fog. I'm not able to understand or do not have the memory. I used to be so sharp. Abhi mere ko yaad nahi rehta phone number and other things. So I think there is a big long-term change. Cough may stay for a while, memory problems. So these are all the things that are something that we are seeing in long haulers, as we call them. Now, I'm going to share this slide for you, not because I want you to be doctors, but because nearly everybody is a COVID doctor. I think it is important for me to discuss a little bit of the way the virus behaves. And that has implications in treatment. I'll come to that. The first part of the virus is a virus replicating. There's a viral response phase. The virus is growing and replicating. And that is the time the patient will have mild fever, dry cough, maybe that diarrhea, little headache, loss of smell, loss of taste. Blood tests at that time will show drop in white cell count. As long as I see low white cell count, I know this is the viral phase. In about the second week, that is why I'm very worried about the second week. That is when the cytokine storm comes. The cytokine storm hits the patient. That patient gets an over-exaggerated response to the cytokines. The body is trying to fight the virus. The virus is inside. It starts shooting the virus. In the process of shooting and killing the virus, it kills itself. So that is the self-destruction or the host inflammatory response. And we see that by high IL-6 values, high D-dimer values. This is the time when most of the damage happens. And so please be aware of the second week. Many patients say, oh, I had fever last week, I should be okay. But when they're about to go home from the hospital or be discharged, they get into trouble. So keep that in mind. The second week, to my mind, is a more dangerous week. A very small percentage will go into the late phase. I will talk to you a bit about that later. And based on this, there are treatments. So therefore, timing becomes a key for treatment of the patient. And Arun mentioned this a little while ago, and I have had discussions with so many people who knowingly or unknowingly blame the medicines. Oh, you know what? Remdesivir is useless. It has never worked. Or remdesivir is God. It works very well. Same is said about interleukin 6. Same is said about convalescent plasma. I think the key lies in this diagram. If this is the early viral phase, then medicines that work on the virus will be the ones which you should use. Unfortunately, people start very early anti-inflammatory medicines, or in the late phase they say abhi remdesivir bhi de diya fir bhi patient mar gaya. The thing is that remdesivir is so you have to time the medicines well, and that is when it will work. So let's go over that. I'll skip this for you, but just to tell you, everybody will not get the cytokine storm. Some people will. These are all the medicines that are there. I just wanted to show you this slide that lots and lots of medicines are available. We know a lot about them, and this remdesivir and favipiravir work exactly in the same way. So don't be hassled. People were saying, oh, remdesivir, we couldn't get remdesivir. Well, then you get favipiravir. It works exactly the same way. So let us see what medicines work in the early phase. As soon as the patient comes, and this is the time when the patient is at home, he needs early treatment, and these are the medicines. First and the most important is nothing. Patient is okay, just give paracetamol, crocin, dolo. Patient, that's all that the patient needs in the early viral phase. It's a mild viral infection in the beginning. I've already talked to you about favipiravir and remdesivir. At least on my part, I believe that the initial phase, if the patient gets a little bit of virus, antiviral like favipiravir, I think it's going to be good. In those who get hospitalized, we give remdesivir because it will, at least any virus that is there, even if it cannot work completely, if it blocks it partly, I think it's worth its money to prevent the virus from replicating. So that's when I use it. Just last week, I have started using monoclonal antibodies, which are more famously known as the Trump medicine. The President of the United States, Donald Trump, got these monoclonal antibody injection. This is for people who are very mild. They are not yet hospitalized. And you give this injection because it is full of spike protein. These monoclonal antibodies are spike proteins. They will block all the spike proteins, and then the virus does not multiply. So it has to be used early. Don't use it late. In India, nobody takes outpatient treatment. I have had patients who got admitted, and within 2 days, instead of giving them convalescent plasma, I've given them monoclonal antibodies. And so far, the results are encouraging. Let me see how it goes. Convalescent plasma has its ups and downs. I think the reason why it will work is because it has good antibodies. The reason why it will not work is if you use it late. If you've used convalescent plasma in the second or third week, it's not going to work. If your donor did not have good antibodies, it is not going to work. If your donor had a different virus from the patient, it's not going to work. So if you select it well, give it early, is going to be a benefit. I've used a lot of convalescent plasma, is going to work. I have no experience of 2-deoxy-D-glucose. This is the one that the DRDO is talking about. It's an old drug repurposed. I hope it works. I really have no idea. Recently, pegylated interferon has been introduced into India. Again, at this moment, I have no experience. It seems at least good, if not harmless. Probably no harm, but I have no personal experience of using it. I've used the first top 3 very, very extensively. I'm very happy with them. And I think the truth of the Mumbai and Lilavati have had one of the best results and outcomes, and we are using these extensively. Now, the intermediate phase is linked into the next phase, but here we give oxygen therapy. Whether I should talk about black fungus now, I think I'll talk about it in a moment. But this oxygen therapy, I think, has an important role to play in the development of the black fungus. I'll come back to that when I talk about black fungus. The later medicines, when the inflammation has set in, now the virus is gone. The body is destroying itself by the production of antibodies. So since the virus is gone and it is destroying itself, the first and the most important is to reduce inflammation. And the best anti-inflammatory drug in the world is steroid. Use it, please use it. It works. It should be used early. So anti-inflammatory should be used. There's a lot of discussion about Tosalyzumab, Itolizumab, and baricitinib. I have used all of them. I think if you time your medicines correctly, if you're able to hit the cytokine storm at the right time, you will be able to prevent the growth and multiplication of the virus. So that is where, if you cannot use Tosi, use Ito. If you don't get Ito, get baricitinib. For God's sake, don't buy 2 lakh rupees ka Tocilizumab in black. Anyway, now it is available, but really was never necessary. And unfortunately, people got cheated. A lot of misinformation, but a lot of disinformation too. Okay. Then the thing that I use on nearly every one of my patients, because I told you the second most fearful complication is clots. So anticoagulants, in my opinion, should be used. Use them judiciously, use them well, and in some cases aspirin. So that's for your doctor to decide. I won't go into any more details, but these are the medicines I think which are on every person's checklist in the later phase. Now I'm going to talk a few minutes because now many of my patients are now in the post-COVID era. They are in second and third month. They are called the long haulers. Maybe 1% or 2% of the population is going to become a long hauler. But that's a large number because a lot of patients suffered, and they will have lingering symptoms going on for the next 2, 3, 6 months. I have a very small number, fortunately, but I have a number of patients who are on steroids for as long as 3 months. 1 month, very fair number of hospitalized patients, but the steroids for 2, 3 months I have seen. I'm using, and please don't worry too much. Lot of patients have taken steroids for interstitial lung disease for 6 months, for sarcoidosis for 2 years, for many conditions for 4 years. I don't think that black fungus is going to come if you have a sensible low-dose steroid. We also give aspirin and anticoagulants. They will be very important managing long-term complication in the long haulers. And one of these are anti-inflammatories, which I just discussed, anticoagulants, antifungals. Now, I want to talk about antifungals at this time. There's a lot of things going on about this black fungus. I'm very happy to say that we have not seen much black fungus. In fact, we have probably got the largest series of treating COVID in the country. We started in March last year, and we are going on. I talked to my colleagues at Lilavati Hospital, and only 3 cases of our own patients who have developed black fungus. And we are seeing the most complicated patients because we get a reference from everywhere else. So why is that so? I think one, we are not using antifungals as prophylaxis or preventive, which I'm seeing in a lot of other places. The other is, I think, we are using a more rational steroid dose. We are using a lower steroid dose than many others are using. Third, I think we were not forced to buy industrial oxygen. Maybe that has got a little more contamination. Fourth, we are not using water for humidification, which is probably a source of infection. 5, we are probably using less of HFNO. So maybe for all these reasons, any of the above, all the above, or maybe God just likes the patients and has been kind to us. But we are not seeing that so much black fungus. We are getting black fungus patients, but from out of Mumbai. So give oxygen, give nasal oxygen, give non-invasive ventilatory oxygen. I have patients who have now got 6 months of oxygen at home. These are the long haulers. You need to take care of them by rehabilitation. They go on to rehabilitation programs, exercise programs. Many will need antidepressants and psychological help. So I think that's a long term. All that being said, let's talk about prevention. You know what? You may not get the vaccine, but you have a vaccine that is cheap, practically free, has been available from the first day of virus, and that is called the mask. Oh, please, for God's sake, use the mask. Unfortunately, it seems that become an ego issue. If I walk from Mumbai outside to even Navi Mumbai, Karjat, nobody is wearing a mask. They had the audacity. Oh, by the way, the background is not abroad. It is Mumbai. It is Karjat. So they say, oh, the Vatavaran idhar bahut acha hai. Idhar virus aayega hi nahi. All got killed because people didn't wear a mask. I'm asked a lot of times, vaccine, oh doctor, which one is better? I said the one which is in your arm is the best vaccine. So take what you get. They're all effective. The duration or the timing of the second dose depends on a particular, whichever one you're using. I think Covaxin is 4 weeks. COVID is, Covishield is about 6-8 weeks. That's okay. The other thing that I'm asked is, I've had COVID, when should I take my vaccine? Well, my real answer is never. You've got enough protection. But that being said, for, vaccine will become a part of your passport. So if you're going to require a vaccine, I think you should wait at least 3 to 6 months before you take the dose, because giving it too early and it will get lost, it is not going to be effective. So I think those are a few answers I have on the vaccines. I've tried to keep it as brief as possible. So it's been a long haul for us. These are my pictures as a corona, shall I say, doctor. And I was honored. It was a pleasure to get the Corona Warrior Award from the governor of Maharashtra a few months ago. Well, it's part of the struggle. We didn't have a choice. We went into war. We did what we had to do. Hopefully, we are seeing the end of it. I began my talk on a very positive note. I think we are seeing the end, or at least we're seeing the beginning of the end. And I hope you all have the strength to go through that last bit. Please do not stop masking. Please help us to help you. With that, I'd like to thank you again for your kind attention. I'd like to thank the organizers and Mukesh Bhai for arranging this program. And I will stop here and thank you for your attention.
Thank you, sir. Very well said. And we promise you that we will follow all the instructions given
guys,
by you.
If I have taken COVID, can I take that? So somebody has asked us about whether they can take tetanus after taking the COVID vaccine. Yes, absolutely. There's no problem with taking the tetanus. That's an independent vaccine. When you take these vaccines like tetanus and all, please be sure that when you take that, you're not on anticoagulants. Don't take an intramuscular injection if you're on blood thinners.
I think few of the questions are answered.
Arun and I have answered all your questions, so there are no questions. And it is 1.5 hours. So if there are no questions, then I leave it to you to wrap up.
Yes. Thank you, sir. I think thank you for your great insights. And as I said, we will promise.
So there's a question coming up. Any test required before vaccination? And the answer is no. Anybody can take it anytime. It's a bit of a fashion to do the COVID antibodies, but realistically speaking, you're going to take, there are two reasons to take the vaccine. One is a medical reason that you don't want the virus. Fair enough. Unfortunately, I think the vaccine is going to become your passport. If you want to go from Mumbai to Lonavala, you probably will have to show a vaccination certificate. If you're going to go from Mumbai to New York, you're going to have to show a vaccination certificate. So in that case, you just have to do it. I think it will be better to do the antibodies as your certification, but they're asking for RT-PCR and vaccination status. So be it. But so in that case, even people who've had the infection, yeah, of getting it. So another question, and Arun, if you can jump in anytime, are there any chance of getting blood sugar while steroids are being given for COVID? Yes. Many of our patients have temporary increase in sugar, and that goes back to normal after the steroids are done. Breastfeeding mothers can take the vaccine. And how to improve your lungs? Breathing exercises. Okay, I'm running through them. Breathing exercises, yoga. I was going to say listen to Ramdev Baba, but these days it's become a bad name. So you can do Kapal Bharti or any breathing exercise. But the best is going to the open air and walk. And it's been clear that vaccine can be given to breastfeeding mothers.
Yeah, thanks, Sanjeev, for all the insight.
Dr. Saab, thank you. I hope we have. Am I audible, sir?
Yes, clearly.
Yeah, because I think there's some problem with my video.
I have something for 3 days, 9900 fever. Somebody had that fever. Post-vaccine, certain things can happen. And Devendra Singh, thank you very much. It's been a pleasure. And thank you for your wonderful comments. Shibab and others. What is the best treatment for asthma? I think that's outside the. वो क्या बोलते थे syllabus से बाहर है ना when you went for an exam. But that being said, I'm an asthma expert. So best treatment for asthma is inhalers. In fact, inhalers protect you against COVID. So inhalers should be used and should be used as long as they're required. Post-COVID, can we take multivitamins? Realistically speaking, the
yes and no.
multivitamins
Yes and no. Vitamins do have
I don't think there's
toxicity,
anything realistic.
Vitamins do have toxicity, so particularly B and D, don't they?
They said that taking the vaccine has precipitated COVID. I don't know. It's a good question. That taking the vaccine has, a lot of people, but a small number of people have got COVID after taking the vaccine. As far as I know, that most people don't.
Sanjeev, there are some
Probably, I think
vaccines.
before they
There are
developed
some.
the antibody. Sorry, aap le rahe ho? Arun, I think
Sanjeev,
you're
what I
muted.
would.
Arun, you're muted. I can't hear you.
No, sir, he's audible. He's audible.
Unmute.
We need to qualify the vaccines, because if the vaccine is a dead virus, there is no way it can cause COVID.
Yeah.
The only argument can be the attenuated virus. One can theorize that it can cause COVID, but that also remains a theory. Now, after vaccination, one can get COVID infection, but that does not mean that the cause and effect relationship exists. So post-COVID infection, I think 1% of the vaccinated people will get COVID, but amongst these people, the COVID will be milder and maybe shorter duration, and it certainly will not lead to a poor outcome. Although there have been some reported cases in which post-vaccine we have had a mortality, but these patients did have other comorbid conditions. I certainly have a close family friend of mine who has been on long-term steroids, and he has had his 2 vaccinations, and the spike proteins have not increased. So he has not formed IgG antibodies. Or let me correct that. He has IgG antibodies, which is probably from exposure to the virus, but he does not have high spike antibodies. But these tests are also not that accurate. So, see, unfortunately, medicine is not mathematics. So 2 and 2 do not make 4 in medicine.
Very true. Very
Yeah.
true. Thank you, Dr. Saab. I think we have almost past 7 and attended all the questions. It was indeed pleasure to host both of you, and full of knowledge. I think full transparency and clarity on the subject. So it was impossible without I think your practical knowledge and your real hard work on field. Once again, I thank you, Mukesh ji, for putting across to both of you. I request our General Secretary Sameer Saxena, or we have a senior member, Captain Rajesh, here to close the session. Sameer or Captain Rajesh, are you there?
Yeah, Abasaheb, I am there.
Please, sir. Good evening.
Okay, good evening. So first of all, thank you so much, sir. We are lucky to have such senior professionals addressing us. So like there were so many questions which in any case you have answered. I'll not have any questions, but I think just few comments. And to begin with, Dr. Arun, I think thank you so much for what we heard, whatever you have done. I think that's a great thing. You obviously gave this new terminology of University of WhatsApp and politicians to decide a lot of things, so which we are ignoring. But one question which is coming from all across, a lot of people, they're still saying that this new vaccine of Russia which is coming in. So the question is, should they wait for that vaccine because claim that's 1 dose, probably more effective, or they should go ahead with the existing available medicines? Because a lot of people are not very sure and they're at that point wherein they have to take a call. What do you suggest, recommend, sir?
Well, I'll answer this question in 2 phases. One is a friend of mine, when I asked him about mutual funds, he says the best way to double your money is to fold it and put it back in your pocket. So then the heap looks double. And I'll come to Sanjeev Mehta, that the best vaccine is the one that is already in your shoulder, you know. So he answered that. So I don't think we must wait for any vaccine. See, all vaccines historically take about 6 to 7 years to mature. Whichever vaccines we have seen in the past, they take 6 to 7 years to mature. New strains of the virus develop, and in fact, the H1N1 virus vaccine we need to take every year. So it might be that you take this vaccine, and the next year, to boost your immunity, you will need to take a different vaccine, or a vaccine that covers a different strain. Now we've got the whole alphabet of alpha, beta, gamma, kappa strains. So you expect vaccines to include those strains. So depending upon the strain that is likely to hit your environment, you will have to take that vaccine. But I feel that we should take vaccine as soon as it is available to us. And I think that is the quote for the day. The best vaccine is the one that is already in your shoulder. Well done, Sanjeev.
Thank you.
Thank you, sir. And sorry, one last question. I'll come to Dr. Sanjeev also. Last question. Since you spoke about steam also, and surprisingly, the question is steam also beyond a point works against the body? Like, is there any limit for steam? And the reason I'm asking this is we had this probably 2 months ago, and again, we had a very respectable doctor. So the question is there a limit to taking steam also?
Arun, that's for me or for you?
No, steam can cause burns.
That's what
So,
Dr. Arun.
yeah, the steam can cause burns. There is no doubt about that. So there is a limit to everything, and there should be a particular temperature of the steam, and steam definitely can cause burns. So steam can damage the epithelium, and then such an epithelium is more vulnerable to the bacteria. So yes, it must be taken in moderation.
As a lung specialist, I
Okay.
would say
Thank
that
you so much, sir.
I have not
Yeah.
used for the last 25 years. Nobody in the
Okay,
Western
sir.
world
No,
uses.
Okay, in a sense, this was one point which Dr. Arun spoke about. So I remember
Oh, you
last time
did?
people
Sorry,
had this
Arun.
question as
I didn't mean
layman.
to contradict
It's very
Arun, but
no. I'm saying, so as a layman, people get confused that like what he's saying is at what temperature, for how long, how good or bad it is. It's a very, very basic question, but at times and since this was there last time also, I said, let me clarify once again, but I think we've got an answer. There's a limit, excess of anything is bad in life. So we need to definitely take some questions also. Thank you so much, Dr. Arun. Coming to Dr. Sanjeev, sir, thank you so much. I think
Captain
whatever you
Sharma,
said,
I can definitely solve the conundrum that the effectiveness of
sure.
steam is probably proportional directly to the prettiness of the nurse delivering it.
Sir, unfortunately, at the stage of steam, you are at home. So you don't have the choice of deciding that. So that's an irony, but I get what you're saying. But I think this is most of the time at the stage of taking steam, you are at home. So there are very limited choices. So that I leave there. And coming back to Dr. Sanjeev, sir, thank you so much. I think very interesting and few symptoms which you spoke about, especially headache, eyes, and all that stuff. I think that's pretty good. So only one comment what I have, and you rather said two things which are very important: the timing of medicine. The problem is, as a layman, this is how doctors advise us. And if you remember, for example, again there was a very famous video of a doctor saying even nebulizer can be very effective for taking oxygen. And those days I remember all nebulizers were purchased by people because that was a time when everyone wanted to do something. So the challenge is to your comment that timing is right. I think this comes from doctors only, and I don't want to contradict anyone, but if they say, and for example, we also spoke about different types of medicine. So this remdesivir, which we never thought we'll ever think of this, so remember this name. Now it's known to everyone because that was the need of that hour. Like every hospital doctor was saying, please get it, and people are running all around. So how to really counter that? I mean, what authority we have as a layman to say whether this is right or wrong? People just follow what they've been told.
yeah. No, I appreciate that, and it's a very real problem. देखिए ऐसा है, you just heard Dr. Arun talk about any vaccine taking 6 years to mature. All the diseases that we are seeing, we have probably 300-400 years of experience. This disease, we don't even have 400 days of experience. अभी तो बीमारी का ही नहीं पता तो उसकी दवाई का क्या पता होगा. So I understand where things are coming from. Somebody sees a little glimmer of hope and he will say, oh, you know what, this works. And in a subset, it probably works. It probably works. I'm not saying it does not work. So my answer to your question is that the science needs time to settle down. What we are seeing is a huge cyclonic dust storm of information. Don't get swept away in that cyclonic dust storm of WhatsApp information. By and large, your doctors are trying to do their best to find the most suitable information for you. Even we don't know. But go to your doctor, have a very intelligent, calm, informed discussion with them. And if they feel at that time it is the best medicine, then we go with it. But that being said, there are a lot of people who are trying to get their 2 minutes of fame in the social media. Don't follow them. Go with, abhi koi bhi humko bolta hai, this works, that works. The first thing that I as your doctor ask him is, give me the evidence. So a good doctor will look for the evidence, will discuss the evidence, then do it. Do not think that suddenly बाकी दुनिया पागल थी, मेरे को नेबुलाइजर मिल गया, मैं अभी सबको जिंदा कर दूंगा. Whoever does that is obviously a clear-cut seeker of social media fame. The person whom you should go with is your doctor who is giving a very balanced opinion. I hope I've been able to clear that doubt. And we also don't know. We also don't know which is the right thing. It will take us time to understand. Like our understanding today is so much better than it was, say, maybe 8 months ago. So things will evolve.
True, sir.
Yeah, go with a good doctor, go with a good consensus, and let them help you to help, help them to help you. I mean, I'll
Thank you
tell you
so
the
much, sir.
problem with
Very
remdesivir.
Ji, sir.
I'll tell you the problem with
Ji, sir.
remdesivir. Problem with remdesivir was like this. If I don't give remdesivir, if the patient dies, they do a court case against us. आपने remdesivir नहीं दिया, patient मर गया. So every doctor went and started giving remdesivir. आपने ये दवाई, आपने टोसिलिजुमैब नहीं दिया ना, पेशेंट मेरा मर गया ना, यू आर रिस्पांसिबल, आपके ऊपर कोर्ट केस कर देंगे, आपको जेल में डाल देंगे. So everybody gives everything. That's what I meant by saying, help us to help you.
No, fair point, sir. Thank you so much. Very powerful. And I think Dr. Arun, finally, what last slide he spoke about, now we realize, and it's very important for us all to also to use that hat to see there are so many issues with the medical fraternity and the sort of overhead burdens we are talking about with the hospitals and doctors. I think that's a very powerful thing, Dr. Ben. Sorry for some strange reasons. Maybe we don't think on those lines, but I think that's very, very effective.
You want to shift?
So thank you so much, even sharing that.
Yeah.
Captain Saab, Dr. Arun has given a task for us as corporate fraternity. I have noted the points, and I promise Dr. Arun that, sir, we will debate on that. If we require any help from Dr. Sanjeev or you, we will come back to you. But yes, I think most of our...
This is a wake-up call for all of us that we keep complaining that the resources are scarce. But if we look at the last 20, 30 years, before 20 to 30 years, all the hospitals in India were trust hospitals. So the government was spending 1% on healthcare. All the government hospitals, they were doing a good job. See, all the government hospitals were teaching hospitals. So all of us trained in government hospitals, and some big corporations had their own medical colleges. So these were medical college hospitals, and they did a good job. However, medicine has evolved. Medicine requires a lot of resources, and the government does not have resources. So the private sector does have to pitch in. So the corporate private sector is behaving like sharks. So they are just picking up hospitals which are made by doctors or they are trust hospitals. There is free property available along with the trust hospital, and the corporates are capturing those hospitals. Even that is a good thing. At least there is facility for the patients. I'm not complaining about that, but we need a lot more input. So nowadays, what happens is it has become the responsibility of doctors in small towns to open their own nursing homes and treat patients in nursing homes where the facilities are inadequate. And even the corporate hospitals are all being opened by doctors. So, so a lot of support is required. That is the point that we are trying to make. And we all look forward to the insurance sector. See, we are very happy that a lot of the population should get themselves insured so that they are not faced with huge bills at the time of crisis. But then the insurance has to reinvest this in healthcare. The insurance cannot just look at profit making. So the insurance has to reinvest a lot of it in healthcare.
No, absolutely, sir. And believe you me, a lot of people have changed their mindset, especially post this pandemic. And I'm so sorry, I know we have taken extra time. Dr. Sanjeev, last thing coming to you. A lot of people are asking, especially till now, this vaccination is up to age of 18. And in a way, I heard you both. Is there anything you recommend, suggest for people to take care of their kids, especially? So wearing mask, social distancing, all those things are done. But anything for those who are not even in that bracket? So any advice from your side?
So I just answered on one of your chats and Q&A. What can you do? So I would think. So it's a very important question. I completely agree. my 4-year-old grandson, we flew him from USA to India. He did not take off his mask in the entire duration for about 32 hours of the flight. अगर बड़े ही नहीं मास्क पहनेंगे तो बच्चे नहीं पहनेंगे. So first is to discipline the adults so they discipline the children. I think the solution lies in the adults. Second, if the adults are partying, just yesterday I have a patient who had very proudly told me, we were having a party in our society till 4 a.m. 50 people in the society. Unke bacche kya karenge yaar? So I think you need to have that. Whereas my nephew, they have yet not gone down for 1.5 years. They are about 8 and 10 years old. So social distancing, masking, COVID appropriate behavior, which means avoiding crowds, follow the guidelines, and you will be pretty safe. Those, and I know that studies are already being done on preparing these vaccines for children. I'm sure they will be safe and effective. The only reason they were not done because the high-risk population, because deaths were seen in the elderly. That is why the initial studies were done in the elderly. I'm sure it will become available for the children. But I think the answer to is insulate your children, isolate them, do COVID-appropriate behavior, keep the distance. If you're going to get them to meet in a class, keep them distant-wise. I think that's the answer. Yes, by and large, fortunately, the risk of patients developing symptoms, children, is less than 0.001. I also told you, I spoke to my pediatrician because my own family member, somebody had COVID and had 2 small children. And I said, what can I do for them? And the pediatrician told me, he said, Sanjeev, if a mother has it, the infants and the children are assumed to have it because they have been together. And if that be the case, then most of Indian children have been exposed. We don't have a study. I think have already been exposed. I don't know about the antibody levels, but I hope that I've been able to give you an answer. COVID appropriate behavior, masking, social distancing, and so soon vaccine will be there.
Thank you so much, sir. This was pretty helpful. Thank you so much to both of you once again. And we are glad that you could spare so much of time. On that note, on behalf of the complete GACS fraternity, we had close to 300-400 people today listening to you. We'll thank you. And if at all there is more demand, we may request you for your time once again. Thank you, Mukesh sir, for organizing this.
Thank you. Thank you.
Thank you.
Abhay Sahib, thank you so much.
Thank you very much. It was my pleasure. Thank you, Dr.
Yeah.
Arun. Thank you, Dr. Sanjeev.
Thank
Really
you.
appreciate considering my request. I am highly obliged to both of you.
Always a pleasure. Always a pleasure.
to
All of
Abha
you be safe. All be safe. All the best.
Good luck, sir. God bless everyone.
Jai Hind, sir. Jai Hind, sir.
Jai Hind. Jai Hind.